In this video, I'm going to talk a bit about the recurrent nevus phenomenon. And this is of particular importance because it can sometimes and quite easily be mistaken for a malignant process, hence its alternative designation, pseudomelanoma. And it's a condition that is mostly a consequence of shave biopsy and to a lesser extent punch biopsy of pre-existent melanocytic lesions. Its importance is that if you don't have the clinical information and you focus too much on the melanocytic component at the epidermis, you can be misled very easily. It's common after shave biopsies and punch biopsies, as I've mentioned, and it may also develop at the site of other forms of previous surgery. It may complicate burns, and it's also been described as a complication of laser therapy. Now, the thing is, the patient initially gets alarmed because it takes quite some time. It might take 6 months or even a year. And then they develop this irregular pigmented lesion. And it can be very variable in appearance. Some areas may be hypopigmented and other areas are very pigmented, or there may be little stipples of pigmentation or linear distribution of pigmentations, or you can even get a little nodule forming. And so the patient or the patient's companion, if it's on the patient's back, sees this lesion and they think, oh goodness, this is not good, because the patients are taught nowadays to always view new pigmented lesions with some degree of alarm. So the patient gets very worried about it and takes him or herself off to the clinician, and then they have a look at it. Now, if the clinician is the person who did the previous shave biopsy, then it isn't so much of a problem. But if it's a different clinician altogether, sometimes with superficial shave biopsies, you don't really get an awful lot of scarring. So the fact that there's been previous surgery may not be so readily apparent. So unwittingly, the clinician may look and say, "Oh gosh, I don't like this very much either," and they send the patient off for further examination and treatment. So the bottom line about recurrent nevi is that we need careful clinical pathological correlation and good clinical history. And also it's very prudent to, if possible, examine the prior biopsy, because nevi can recur at the site of the previous biopsy, but so can melanoma. And so if the histology of the recurrent lesion is very problematical, then it's really essential that you view the prior biopsy to make sure that you're happy that it was indeed a benign lesion. Now, the histology can also be very problematical, and this is where you need to see the big picture. There's a tendency, I think, among pathologists when they see an atypical looking melanocytic junctional proliferation, they tend to dive down with high power magnification on the melanocytes and lose track of what's going on around. And so you need to look carefully at low power. And if you do that, then you'll see the scar tissue and you may see residual dermal nevus, as in this image on the right-hand side. There's a junctional melanocytic proliferation, but we can also see residual dermal nevus cells in the right-hand corner, and there's clearly scarring extending along, and there's a little bit of pigment, a melanophage full of pigment. Now, the general rule of thumb is that the recurrent, well, I'm going to mention just briefly, it's not really a recurrent nevus at all. That's a misnomer. What it really is regrowth of the nevus, and that's because the nevus was not fully excised, and so nevoid cells can start proliferating again, both from the epidermis and from the folliculosebaceous units, and so they regrow. It doesn't recur, but that's a small point. The important thing is the junctional component does not extend beyond the extent of the scar, and the junctional component can be epithelioid or spindled, and it can show anything from mild all the way through to severe cytological atypia, and you may get 1 or 2 Pagetoid cells as well. So if you focus wholly on the junctional region, you'll end up thinking something's maybe an in situ melanoma. So you have to take things in context. So I'm going to show you a series of examples now, just so that you can get your eye in for what recurrent nevus looks like. Once you do that, then I think you're unlikely to fall into a trap of calling something like this a melanoma. The first thing you can see that there's massive, absolutely massive scar tissue all the way, involving most of that section, and I'm not certain, but I think this probably implies that the patient had a pre-existent congenital nevus, which would account for the depth of the excision. But you can see that there are large junctional nests and 1 or 2 nests in the very superficial dermis. So let's look at those at higher power. And if we look, what we can see is a rather worrisome population with prominent nucleoli. The nevus cells are big, and there's a huge nevus cell there. It's well over twice the size of a keratinocyte in the mid-prickle cell there. So that nucleus is shows severe cytological atypia, and the others, perhaps we might call them moderate. So on its own, this would be quite worrisome. And there's a higher power view of a different part, and again you can see the prominent nucleoli. And there's the dermal part, and again, if we just had the junctional component and these 2 pretty large nests, I think we'd be very worried about it. We might start worrying about melanoma, but the dense scar tissue helps us keep to the the right pathway, and clinical information will reveal there had been a previous biopsy of a nevus at that site. Now, it's very important that you guys don't just say, oh, well, I didn't get any history, because that is the road to ruin. If you don't get the clinical history, you're not going to be able to view the lesion in the proper context, and you're much more likely to make a mistake. So you just have to learn to badger the physicians, the dermatologists, the general practitioners, badger them until they get the idea, they get the message to give you the clinical information. This is another one. This is case 2, and this is quite nice because it's got a hypertrophic scar. You can see it's sort of it's an oval sharply circumscribed nodule of scar tissue. So this is a hypertrophic scar, and there's not much going on in the overlying epidermis. There's a little bit of junction activity, but this lesion was probably biopsied because of the scar, not because of the regrowth of melanocytes. There you can see that there is some junctional activity, and it's showing a rather spindled character rather than epithelioid, or there are a couple of epithelioid cells there, but it's not desperately worrying. We can see, as I showed you earlier, there's the residual dermal nevus. And there's a close-up view. I suppose with these prominent nucleoli, you would certainly regard these cells as severely atypical. Now, this is a different case, and I'm sorry, it's a rather, the color is not very nice, but that doesn't really matter too much. What we can see is we can see almost a dome-shaped nodule with a hair follicle bisecting it, with two large collections of dermal nevus cells on either side. We can also see that the nevus extends laterally on both sides, and that there is a junctional proliferation overlying some superficial scarring. And a slightly higher power view, emphasizing the junction activity, the scar tissue, the nevus, and again in close-up here. None of this is worrying. This is clearly just a residual compound nevus. Now this is a different case, and this one's quite striking. That there's residual nevus at the top, and then we've got this scar tissue, and then we've got very, very spindled nevus cells in large nests, and then over here you can see it's bridging across a number of well, the rete ridges are actually effaced, but if they were there, would be bridging across a whole bunch of them, and there's more of it there. And if we look at that carefully, we can see it's a spindle cell population, and it's something that would worry you, particularly if there wasn't any scarring present or there wasn't a pre-existent nevus. You would certainly regard this as an atypical junctional melanocytic proliferation. It may be difficult to classify it further, mind you. And here's a recurrent Spitz nevus. So there's a nice Spitz nevus at the top, and there's scar tissue, and there's residual, the dermal component of the nevus. Not a difficult diagnosis, but just to show you another example of the phenomenon. And there's beautiful Spitz nevus, very nice population of discohesive cells, spindly, with regular nuclei. I don't think that would worry anybody. And there's the dermal component there, where you can see nevus cells extending deeply into the reticulodermis. Now this one is a bit more problematical because it's very atypical. We can see a congenital nevus. It's congenital because it's hugely thick, and it's going all the way down to subcutaneous fat. But what we see at the top is a thick zone of scar tissue going all the way across the top of the specimen, and then there are multiple junctional nests and some heavily pigmented dermal nests at the top of the at the bottom of the scar. So this is this is a section or an image taken just at the edge of the scarring. There's a small junctional nest there, but this is the dermal nevus population, which looks very bland. And at higher power magnification, there's nothing there to worry us. The nevus cells are uniform. They're round, they have a small nucleolus, they're utterly bland, and this is nothing more than nevus, so we don't need to worry about that. Here is the top of the lesion, and as I mentioned to you at the start, the nevus can regrow from the epidermis or from the follicular-sebaceous units, and here we see this happening with lots of junctional nests arising, and there are bits of hair shaft there in the middle, and there are also heavily pigmented dermal nests, and there's a bit of junctional activity coming off from the epidermis. Now, one of the problems with this particular biopsy is the junctional activity is quite worrying. If one looks at this field, we can see that there are very large nests. There's a retraction artifact. The nevus cell population is very discohesive. And the pigmentation is finely granular. In fact, this field here, if we just took that, it really reminds me of a nevus of special site, which is quite interesting. And there's more residual bland-looking nevus cells, and there's a nest in a pilofollicular unit. And if we look a bit more closely at these nests, they become even more worrying. And there's a high power view showing severe cytological atypia. So if you had this image out of context, I think you'd probably call it melanoma in situ. So it emphasizes yet again, and I'll go on and on about it, clinical information, clinical pathological correlation is essential to avoid misdiagnosing these lesions as melanoma. And there are a couple of nests at the side, and again they show this finely granular melanin deposition, which always worries me a bit. And there's the nevus cells in this sebaceous gland. That's quite a nice, pretty appearance. And in this case, we can see again. It's important to get things in context, to see the big picture, as folk like to say. It's regrowth of a nevus. There's a great big scar in the middle. There's the residual nevus cells at the base of the lesion, and then we can see some nests overlying the scar, and there's a junctional component there. And if we look more closely, on the right, we're happy that we're looking at residual dermal nevus, but you can see rather a worrying junctional component, and these nests are of concern. If the specimen was just along that line, above that line, so you didn't really see much of what was going on, you'd be very worried about it. And here's a close-up view showing severe cytological atypia, very prominent nucleoli, and Pagetoid spread. It would be awfully easy to call that in situ melanoma. So make sure you know the history, and make sure, if you at all possible, you review the previous slides to make sure the diagnosis of nevus was correct. And this is the last case. In this one, there's very dense, hyalinized scar tissue in the dermis. So there's enormous scarring. And there we have the junctional component with fine stipple pigmentation, and then these large residual nests of nevus cells in the bottom. Now, I suppose it would be very tempting to call this a recurrent nevus, and it sort of is in a very, very obtuse way, because this is not a recurrent nevus at all. This is a nevus of special site. This is a nevus from the umbilicus, and at the umbilicus you expect to see all this scar tissue. It's normal. So there you are, nevus of special site in the umbilicus. And there's a field there that would make your hair stand on end if you didn't know what this was. That's very worrying. And in the same lesion, there's the most wonderful bridging I've ever seen. The bridge, it goes 1, 2, 3, 4, at least 5 reedy ridges. That's the longest nest you'll ever see. But in the context of a nevus of special site, it doesn't matter. And there's moderate to severe cytological atypia. And there's the dermal component, a beautiful population of type B nevus cells that they almost look punched out or painted on. They're very pretty. Blue cells, sharp nuclear margins, minimum cytoplasm, and they're very uniform. So those are type B nevus cells. And then lastly, I just wanted to remind you not to forget about partial regression in a melanoma. And in partial regression, one still sees evidence of melanoma in the overlying epidermis. You may see some apoptosis, as we see where the arrow is there and there. Those are apoptotic tumor cells. And then in the dermis, we see striking vascular ectasia and vascular neoproliferation, which is a feature of regression. If you look carefully, you can see there are blood vessels all over the place. And then we've got lymphocytes, melanophages, and a rather loose fibrous tissue. So don't forget about a partially regressed melanoma when you're looking at these cases. Although I hope I've shown you enough cases that will keep you out of trouble. And so the bottom message, as always, clinical pathological correlation is critical. And this last image is a lovely case that I put in that Eduardo Calangi shared with me. This is a proliferation nodule showing osteoid formation. Well, I hope you find that video useful, and if you like it, I would be grateful if you clicked on the like button. It will help me a lot. Thank you very much for your time.